Yep, that worked. Okay, and I'll just introduce you. Okay, good morning all. It's 8:01. We've got the great pleasure of having Professor Ryan Tedford today for grand rounds at Cardiac Sciences Grand Rounds. Professor Tedford obtained his medical degree at the University of Texas in Southwestern Medical School in Dallas, and then he completed his internal medicine training and additional years as an assistant chief of service, cardiology fellowship, and advanced heart failure and transplant training at Johns Hopkins School of Medicine. He joined the Medical University of South Carolina back in 2011, where he came as the chief of heart failure and medical director of cardiac transplant. He's been there since then. He's a professor of medicine and cardiology, also directs the advanced heart failure and transplant fellowship programs at MUSC, and he holds the Peter C. Gazes Endowed Chair in Heart Failure. Dr. Tedford is an internationally recognized clinical researcher and has published over 150 peer-reviewed original papers. He's an invited expert, and he is a great lecturer and been invited to many national and international scientific meetings. He has a lot of other appointments, and he also is a section editor for the Journal of Heart and Lung Transplantation, and he's on the editorial board of Circulation, Heart Failure, JACC, and Chest. So it is a great pleasure to have Dr. Tedford talk to us about assessment of right ventricular function and the role of RV-PA coupling in RV reserve. So Ryan, thank you very much for joining us today.
Carlos, thanks very much for the kind introduction and for the warm welcome. It's really a privilege and honor to be speaking to you all today, and especially folks like Professor Tyberg and Westerhold as well. With that in mind, these are my disclosures, none of which should be particularly relevant for the discussion this morning. Over the next 45 minutes or so, I would like to meet the following objectives with you. We're going to begin by describing a clinical observation and ultimately—
Ryan, sorry, your slide didn't advance. Sorry. You're still on your first slide.
All right, I'm going to try one other thing here. I think by now we would have this down, right?
Yeah, you know, there's always something, but that's fine. Well, it's a nice campus, I can tell you that.
It is nice. How about now? Is that advancing?
Yep, we got it.
Okay, terrific. These are my disclosures here. Again, the objectives that I'd like to meet with you over the next 45 minutes, we're going to begin by describing a clinical observation, and importantly for the trainees, what ultimately led to be an incorrect theory that led us to investigate right ventricular loading conditions in a condition called systemic sclerosis or scleroderma. We'll discuss how contractile differences rather than unmeasured afterload accounted for our clinical observation. And in the second half of the discussion, we're going to praise some emerging data on the role of right ventricular reserve measurements, including potential diagnostic and prognostic implications. I think many of you all are familiar with the disease of systemic sclerosis or scleroderma. It's a condition that's characterized by multi-organ fibrosis, immune abnormalities, and microangiopathy. You'll see there on the top left-hand side of the slide, the microstoma, the telangiectasias on the face, the skin tightening with sclerodactyly. These patients have esophageal dysfunction, interstitial lung disease. They have the microangiopathy that leads to Raynaud's phenomenon, renal angiopathy, and of course, pulmonary hypertension and RV failure in some patients. Now, it turns out the causes of death in systemic sclerosis have really dramatically changed over the last few decades. When we look back into the 70s, the leading cause of death in these patients was scleroderma renal crisis. But with the advent of ACE inhibitors and the realization that they can treat acute crises, the causes of death from scleroderma renal crisis has steadily declined, and unfortunately has been replaced by lung complications, among which is pulmonary arterial hypertension. This is one of the first studies performed by Micah Fisher and Paul Hassoun that looked at the prognosis in patients with scleroderma-related pulmonary hypertension and found that indeed the prognosis was much worse than in other forms of pulmonary hypertension, here specifically idiopathic pulmonary hypertension. You can see in this early study that the survival after diagnosis was only about 3 years. Along the same time, they made some interesting hemodynamic observations. They found that the patients with systemic sclerosis, pulmonary hypertension actually had lower pulmonary pressures and lower pulmonary vascular resistance, yet had similar degrees of depressed cardiac function compared with those with idiopathic pulmonary hypertension. So when we think about what might cause that, there's really two possibilities. The first is that these patients actually have intrinsic right ventricular contractile dysfunction, and perhaps that's due to fibrosis, inflammation, the small vessel microangiopathy leading to ischemia that we discussed. Or perhaps these individuals have a lung problem, and that pulmonary vascular resistance may not accurately reflect the load imposed on the right ventricle from the pulmonary vasculature. And perhaps there's an increase in what we'll call pulsatile loading due to stiffening of the proximal pulmonary arteries. And being a cardiologist, I try to blame the lung whenever possible. And so this was actually our hypothesis. Hypothesis is that these patients had unmeasured pulsatile afterload that was contributing to this RV dysfunction. So let's take a step back for a minute and discuss afterload in the systemic circulation. This is a bit of an oversimplification, but in general, we can think of afterload as having two main determinants, compliance and resistance. And in the systemic circulation, most of the compliance or blood storage capacity of the system is located in the proximal aorta. In fact, that accounts for about 80% of the total compliance, where the smaller vessels account for only about 20% of the total compliance. The resistance, on the other hand, is all accounted for in those small distal arteries and arterioles. As we know, that resistance is inversely proportional to the radius of the vessel. Now, blood, of course, is not just steady state, but it is pulsatile. And these pulsations will travel down the aorta. They will meet reflection points in the periphery and results in wave reflection. Now, in a healthy individual, normally this is a very little consequence, and pressure will actually decline at the end of systole and continue to do so during diastole. And on the upper left-hand portion of the slide is aortic pressure tracing. Now, with aging, we get stiffening of the proximal aorta. This lowers our large vessel compliance. This results in an increase in pulse wave velocity. These pulses meet the periphery, result in enhanced wave reflections that travel back more quickly. And this results in an elevation of left ventricular afterload because these pulsations will reach the heart at the end of systole. And this will lead to pressure augmentation seen on the aortic pressure tracing. We also call this the augmentation index. Now, important thing to keep in mind here is that there is a difference in geographic distribution here of compliance and resistance in the systemic circulation. Compliance is proximal predominantly, and resistance is more distal. So let me summarize what I just told you. Again, a little bit of an oversimplification, but most of the vascular compliance is located in the proximal vessels, that is the aorta. With aging, compliance can decrease with less effect on resistance, and that's because of a difference in geographic distribution of these two components of afterload. The net effect is increasing left ventricular afterload due to enhanced wave reflections and pulsatile load. And importantly, this afterload is not measured by systemic vascular resistance, which takes into account only mean pressure and mean resistance. So as we turn our attention to the lung circulation, I'll just remind you that pulmonary vascular resistance, which is how we commonly estimate afterload in the cath lab, only accounts for mean or steady state flow, because we calculate this as mean pulmonary artery pressure minus the left atrial pressure divided by the cardiac output. But just like in the systemic circulation, there's pulsatile flow in the pulmonary circulation, and pulmonary arterial wave reflections can return during ventricular systole to further elevate right ventricular afterload. And so the question at hand is disease states like pulmonary arterial hypertension, advanced age, and in our situation, specifically connective tissue disease related pulmonary hypertension, lead to stiffening of the proximal vessels and higher pulsatile afterload. And in fact, just a decade ago, this was a leading hypothesis that pulmonary vascular wall thickness was a major contributor to right ventricular afterload in pulmonary hypertension. So how do we assess pulsatile afterload? Well, probably the purest way is to go back to the days of Milner and O'Rourke back in the 60s and measure it directly with pulmonary input impedance spectra. This is a bit complicated as it requires Fourier analysis of simultaneous measures of pressure and flow, and it's measured and reported in the frequency domain rather than the time domain. So it's a bit difficult to measure and also to interpret. Now we can also estimate total load on the RV pressure volume loop through something called effective arterial elastance. And this includes both pulsatile components and resistive components. But perhaps the simplest way is to estimate pulmonary compliance. And again, there's some assumptions here, but we can estimate it as stroke volume over a pulmonary pulse pressure. And this should, to some degree, account for wave reflection, because wave reflection will augment that systolic pulmonary artery pressure without much change in diastolic pulmonary artery pressure, and therefore will increase the pulmonary pulse pressure. So in the mid-2000s, there was some very interesting work coming out of the Van Noordegraaff group in the Netherlands. And they were really some of the first to describe a unique relationship in the lung between resistance and compliance. So here was their first study of just 29 patients that included patients without pulmonary hypertension, those with chronic thromboembolic disease, pulmonary hypertension, and those with idiopathic. And what you can see here is that the resistance and compliance relationship follows this inverse hyperbolic conserved relationship, such that as resistance increases, compliance decreases in what appeared to be a predictable manner. And this also implied that the RC time, or diastolic decay constant, in the pulmonary artery may in fact be relatively well conserved and constant. The group went on to actually show this relationship held true before and after treatment for pulmonary hypertension. You can see with treatment of PAH, resistance declined, but compliance increased in a predictable manner and followed that same hyperbolic relationship. And therefore tau, or the RC time, actually was unchanged in this group. They went on to measure the RC time in patients with chronic thromboembolic disease, measured in each individual lung, ones that had normal flow, ones that had low flow due to obstruction, as well as both lungs put together. And at least in this small study, there was no appreciable change in this RC relationship. And on the bottom right-hand side of the slide, you can see the RC time was relatively constant. We found this quite fascinating. And so we looked at over a decade worth of patients, Johns Hopkins, who either had known or suspected pulmonary arterial hypertension. Importantly, these patients all had a normal left atrial pressure. And we found a very similar relationship to Dr. Van Noordegraaff's group, this inverse hyperbolic relationship between resistance and compliance. When we looked in the systemic circulation, we did not find that same conserved relationship. You can see there's a lot more variability. And this is perhaps best appreciated when you plot the RC time of the pulmonary and systemic circulation against mean pressure. Here, the open dots represent the pulmonary circulation. And you can see the RC time, although there is some variability, is more highly constrained around 0.5 seconds, where in the systemic circulation, you can see there's a lot of variability. And at least in part, again, that's because in the systemic circulation, we can change compliance independent of resistance. So we wondered, does aging alter this relationship like in the systemic circulation? So we took those same 1,000 patients, we divided them into age tertiles. Here the black dots are the youngest group with the red dots being the oldest. And first, on the left-hand side of the slide, you can see the pulmonary RC relationship. And in general, you see that those different colored dots are fairly evenly distributed across that RC curve, with a slight shift to the left within the older age population. But compare that to the systemic RC relationship on the right-hand side, you can see the older individuals really dominate that lower compliance portion of the curve. And so really a very significant difference between the two circulations. We then wondered, did a severe interstitial fibrosis alter this relationship? And so we collaborated with David Leder at Columbia and looked at 89 patients with severe pulmonary fibrosis. Not a lot of pulmonary hypertension here, but you can see those individuals fit very nicely onto our previously derived RC curve from our cohort of patients with known or suspected pulmonary hypertension. We thought this would be an interesting way to test the hypothesis in systemic sclerosis that they may have unmeasured load. And when we compared 67 idiopathic patients to 166 patients with systemic sclerosis, we really found that the RC curves were superimposable, really no difference. And again, highlighted here, the RC time versus mean pulmonary artery pressure, and no difference between the groups. So what might this and other work like this tell us about afterload in the pulmonary circulation? Well, I believe that it's different from the systemic circulation, and that most of the compliance is actually not located in the proximal vessels. The proximal vessels account probably for only about 20 to 25% of the compliance. And why is that? And it's because compliance is more evenly distributed across the pulmonary bed. And it's the peripheral or distal vessels that are responsible for vascular compliance, the same ones that are responsible for resistance. And the reason for that in part may just be the number of peripheral vessels. We know there's about 8 to 10 times more peripheral vessels in the pulmonary circulation compared to the systemic tree. And so there's a lot more blood storage capacity out at the periphery in the pulmonary circulation compared to the systemic circulation. So a lot of that work is a bit theoretical. And so I think this animal model further proves this point. This is work from Kuo and colleagues who developed this in-series compliance and resistive chamber. You can see that that compliance chamber has the ability to become very, very stiff or be highly compliant. And then just after that, there's a variable resistance clamp. And so they took a sheep and they connected this to the very proximal pulmonary artery, and they reconnected then the circuit to the natural lung of the sheep. So they maintained the compliance in the lung. So the first thing they did is they actually changed pulmonary vascular resistance. They tightened that resistive clamp. And as you can see, as the pulmonary vascular resistance went from 2 to 4 to 6 to 8, the change in cardiac output was pretty significant. So the PVR of 8, cardiac output declined by about 50%. But when they altered compliance from a very highly compliant chamber to a low compliant chamber, you can see that the change in cardiac output for any given PVR was actually quite minimal. So looking back at our two hypotheses, in fact, we appear to be wrong. And in fact, these individuals may have intrinsic right ventricular contractile dysfunction. So then the question came up, how do we best assess right ventricular function? Well, anytime someone gives a talk about the right ventricle, they always show this classic paper by Abel and Waldison, where they took dog models and they changed pressure acutely. In the right ventricle of this dog, you can see that an increase of mean pulmonary pressure of about 15 millimeters of mercury decreased stroke volume by about 30%, whereas in the left ventricle, an increase of 40 millimeters of mercury only increased stroke volume or decreased stroke volume by about 10%, speaking to the afterload sensitivity of the right ventricle, at least in the acute setting. But I think what is perhaps less appreciated is that the right ventricle is afterload sensitive even in the chronic setting. This is work from John Newman and Anna Himnes at Vanderbilt. They took patients who had vasoreactive pulmonary arterial hypertension and measured hemodynamics before and after administration of inhaled nitric oxide. Now, as you would expect, because of their diagnoses, these patients had significant decreases in pulmonary pressures as well as pulmonary vascular resistance with inhaled nitric oxide, and this resulted in a robust increase in stroke volume. And so it really speaks to the idea that RV function is determined by coupling of RV contractility to afterload. And many of our clinically used measures of right ventricular function, that is stroke volume, RV ejection fraction, fractional area change in TAPSE, are load dependent and may not give us real information about the intrinsic ability of the right ventricle to stiffen and contract. So how do we best assess RV contractility? And to tackle that issue, I'm going to take you back to the pressure volume loop. And just to get everyone on the same page, we'll go through a single pressure volume loop here, which represents a single cardiac cycle. We're going to begin at the end of diastole. Here, our tricuspid valve is closed. And the RV end diastolic volume here is our preload. The first phase is isovolumic contraction. We have a rise in RV pressure without any change in volume, at which point the pulmonic valve opens up. We begin ejecting into the pulmonary circulation, so the RV volume declines, at which point the pulmonic valve closes, initiating the onset of diastole. We have our isovolumic relaxation with a decline in pressure without much change in volume, until the tricuspid valve opens and the right ventricle fills again. And the width of that pressure volume loop is, of course, stroke volume. Now, we can measure RV contractility with pressure volume approaches based on the assumption that the ventricle is an elastic structure that will stiffen and relax along a predictable time course in the cardiac cycle. And so if we create a family of pressure volume loops through preload reduction, we can determine the end systolic point for each of those loops, and that's the ratio of maximal, or the maximal ratio of pressure and volume for each loop. When we connect those end systolic points, we establish the end systolic pressure volume relationship, the slope of which is the end systolic elastance. And this is a relatively load independent measure of contractility. Now we can also estimate afterload on the pressure volume loop. And so it turns out that if we could sum up the systolic pressure throughout ejection, this would be a reasonable measure of afterload. And so if we take the end systolic pressure and we divide that by the stroke volume, this gives us the effective arterial elastance. And this is a lumped parameter of afterload that will account for both resistive and pulsatile components. We can then look at the ratio of those two elastances to determine coupling between the right ventricle and the pulmonary arterial circulation. So we know from Suga and Senagawa and my mentor, David Cass, that these pressure volume loops can be performed in the left ventricle, but the right ventricle is a different beast. It's highly trabeculated, it's a different shape. And so it's a little perhaps unclear if this type of measurement is feasible. The first RV pressure volume loop ever performed, to my knowledge, was done in the basement of Johns Hopkins by Mike Weisfeld and Lowell Mon. This was done in a normal tensive dog, and you can see that the pressure volume loop shape is actually quite different. It's more triangular. Pressure falls throughout ejection because these hearts are ejecting into a very low impedance circuit of a normotensive pulmonary circulation. But what Dr. Mon and Dr. Weisfeld showed is that this technique was feasible and that the end systolic pressure volume relationship was sensitive to changes in inotropic stimulation with dobutamine as well as beta blockade. So we thought this would be a good way to test for changes in contractility in our population. So this is an example of a pressure volume loop we performed in a patient with pulmonary arterial hypertension. You can see with preload reduction, the blue line there represents the end systolic pressure volume relationship, and we see a very nice result there. And so when we looked at our initial cohort of patients with idiopathic and scleroderma-related pulmonary hypertension, you can see here that the end systolic elastance was actually different between the two groups. The idiopathic groups, you can see the line is actually much steeper compared to the patients with scleroderma. This was a summary of our initial data set, and I want to point out here that the RV ejection fraction was actually equal between the two groups, yet there were significant differences in contractility as measured by the end systolic elastance. RV afterload was actually not different, and therefore the ratio of elastances was preserved in the patients with idiopathic pulmonary hypertension and much more borderline in the patients with scleroderma. But let me take you through what I just told you. So if you have a normal right ventricle and you develop pulmonary hypertension, you have an increase in your load. But in individuals who have a normal RV, you can increase contractility to match that load. The ratio of elastances is preserved and RVPA coupling is preserved. But if you have a diseased right ventricle, for example, in patients with scleroderma, perhaps in those patients with heart failure with reduced ejection fraction, or even in HFpEF, as we increase load, contractility may be saturated and cannot further increase to match those increases in load. The ratio of elastance declines and the RVPA unit becomes uncoupled. Now, invariably, whenever I've given this talk in the past, somebody kind of raises their hand in the back and said, well, that's great, but do you have any evidence that this actually predicts outcomes in patients with pulmonary hypertension? And over the last couple of years, I think we have a couple studies that have shown this. The first is by Tello and Richter from Germany. They performed this multi-beat pressure volume analysis in 38 patients with pulmonary arterial hypertension. And they found at a cut point of around 0.7 that this nicely discriminated patients who ultimately developed a clinical worsening with pulmonary hypertension. We looked at our own data, 28 patients with pulmonary hypertension. And I think our data is a little bit unique because these patients had preserved RV ejection fraction at rest, but actually found a very similar cut point, that a cut point of 0.65 discriminated those who ultimately developed clinical worsening due to their pulmonary hypertension. Our other parameters based on MRI and hemodynamics were actually no different between the groups. More recently, we've collaborated with Tim Lamb and again, the group in Germany, and have looked at multi-beat pressure volume analysis to try to understand the sex differences we see in RV function. And in these cohorts of patients with pulmonary hypertension, all comers as well as idiopathic, we can see that women tend to have higher contractility and more preserved ratio of elastances compared to men. So let me summarize the first half of the talk. One, I've told you that the proximal vessels contribute only a fraction to the overall afterload in the pulmonary circulation. Many of our measures of RV function are load dependent, yet are not true measures of RVPA coupling. Systemic sclerosis related pulmonary arterial hypertension patients appear to have intrinsic RV dysfunction and an inability to compensate for increases in load. And finally, while pressure volume analysis is the gold standard and predicts prognosis in pulmonary hypertension, is probably not feasible for clinical practice. And so then that takes me to the second part of the discussion this morning, and that is, can we use RV reserve to predict or to help us with diagnosis, predict prognosis, and can it be a surrogate for RVPA coupling? So first of all, what is reserve and what information can it give us? A contractile reserve is the capacity of the ventricle to increase contractility at a given level of loading. And typically that's determined either using exercise or a pharmacologic stimulation like dobutamine. Is there a diagnostic value of RV reserve? This is a study by Marco Guazzi and Milan in patients with heart failure and reduced ejection fraction who underwent an echo stress test as well as cardiopulmonary exercise testing. Now, the first thing that he did with these 97 patients is he grouped them based on their resting RV function. So group A is those with a TAPSE that's in the normal range, greater than 16 millimeters. And group B are those with less than 16 millimeters, so they had resting RV dysfunction. He then further subdivided that group with resting RV dysfunction into group B, those who actually augmented or maintained their TAPSE during exercise, and group C, those who actually had a decrement in TAPSE during exercise. He then compared these groups in terms of their functional capacity. So group A and group B, again, group A, normal resting RV function, group B, those who had evidence of RV reserve, actually were fairly indistinguishable in terms of functional capacity. They had similar peak VO2, they had a similar peak O2 pulse and estimate of stroke volume, similar VE/VC2 slope, and similar degrees of exercise oscillatory ventilation. But group B and group C were actually quite different. Again, the group C are those who lacked reserve. These individuals had lower peak VO2, lower peak O2 pulse, higher VE/VC2 slope, and more significant exercise oscillatory ventilation. What about in HFpEF? This is work from Barry Borlaug, who took 50 patients with HFpEF and 24 controls and performed invasive cardiopulmonary exercise testing along with echocardiography. There was no difference in these groups within resting cardiac output or stroke volume, and there was no difference in resting RV function. But when he exercised these individuals, you can see that there were significant differences in terms of both LV and RV reserve. Here, the individuals with HFpEF had less increase in their S prime during exercise compared to control individuals. What about in pulmonary arterial hypertension? This is work from Sharma and colleagues published in the European Respiratory Journal about 5 years ago now. They took 16 patients with pulmonary arterial hypertension and 18 age-matched controls. They gave these individuals dobutamine and had two different measures of RV reserve. The first was change in S prime and the other was change in TAPSE. Now, when you compare controls to pulmonary arterial hypertension, you can see in general, those patients with pulmonary arterial hypertension had evidence of less reserve, and that's probably expected. But now draw your attention to the different colored dots. So the red dots within pulmonary arterial hypertension subgroups have depressed cardiac function at rest, where the open dots actually had normal RV function at rest. Yet those individuals with normal RV function at rest still had evidence of contractile reserve impairments compared to the controls, so suggesting these individuals may have hidden right ventricular failure. Let's move on and talk a little bit about the prognostic value of RV reserve. The first study, again in heart failure with reduced ejection fraction, comes from a group in Japan who performed dobutamine stress echocardiography in 104 patients with dilated cardiomyopathies. They had 3 different measures of RV function, fractional area change, TAPSE, and then measures of longitudinal RV free wall strain. When they compared those individuals who had a subsequent heart failure event compared to those who did not, you can see the ones who did not have a future event had evidence of RV reserve, no matter how it was measured. And those who subsequently had a heart failure event lacked significant changes with dobutamine. Greg Lewis and Doreen DeFaria at MGH have suggested RV reserve is also prognostic in patients with congenital heart disease. Greg and Doreen developed an RV score based on changes in RV ejection fraction during peak exercise, as well as the peak RV ejection fraction that could be maintained. You can see in this cohort, those who had evidence of good RV reserve had excellent event-free survival at 2 years of follow-up, where those who had the most severe impairments had worse event-free survival. We have recently looked at the ability of RV reserve to predict right heart failure after implant of a left ventricular assist device, and we're taking a little bit of liberty here with our definition of RV reserve, as we've looked at the changes in hemodynamics with a pure vasodilator, that is, with infusion of nitroprusside. So this is a multi-center collaboration at our center in MUSC, the University of Pennsylvania, and then your colleagues in Toronto. We found 71 patients who had combined pre and post capillary pulmonary hypertension. That is, they all had a pulmonary vascular resistance greater than 3 Wood units. They underwent vasodilator testing with nitroprusside and eventually had an LVAD implant. What we found is that their peak stroke volume index was a good discriminator of those who did and did not develop early right heart failure. And you see specifically if their peak stroke volume index with nitroprusside was less than 22 millimeters per meter squared, those individuals had a high likelihood of developing significant right heart failure after implant. And in multivariate analysis, it was only peak stroke volume index that was associated with early right heart failure. And for every 1 millimeter per meter squared decrease in stroke volume index, it was a 16% increased risk of right heart failure. As I was preparing this talk, I actually remembered this paper that Jason had published last year in CHEST and actually found it very similar to the work that we just performed. Jason and your group looked at the ability of stroke volume index by echo to predict subsequent outcome in patients who are admitted with acute intermediate risk pulmonary embolism. Outcome here was defined by in-hospital death or cardiopulmonary decompensation. And what you can see here is that stroke volume index had the best sensitivity and specificity for predicting that primary outcome. And in fact, the cut point was very similar to what we found. Cut point here in this study was 20 milliliters per meter squared. And although you might say, well, these were resting measures, in fact, I would say these individuals were stressed by this acute PE. And so in fact, perhaps this was actually a measure of stroke volume index reserve. So can we relate resting RVPA coupling, the gold standard, to measures of RV reserve? This is a study by Guerre and colleagues. They had piglet models of pulmonary hypertension. They measured gold standard pressure volume relations and then gave these piglets dobutamine and looked at changes in stroke volume index. As you might expect, the piglets with the most severe uncoupling had the least increase in stroke volume index with dobutamine. And the authors found a relatively linear relationship between stroke volume index reserve and resting RVPA coupling. We wanted to study RV reserve in our population of patients with scleroderma. And so this is what it would look like in the cath lab. We have a supine ergometer at the end of the cath lab table. We'll have our exercise physiologist with a metabolic cart so we can measure oxygen consumption. We'll have our PV loop Inca machine present, and then a lot of support staff. This was our RV reserve protocol. We first performed the clinically indicated right heart catheterization. We next performed an RV septal biopsy for research purposes under the guidance of echocardiography. We performed our resting pressure volume measures, and then we performed pressure volume measures during both right atrial pacing, followed by symptom-limited supine exercise. The first thing I'll show you in our new cohort of patients is that we reproduced what we had seen in the earlier cohort between showing contractile deficits in the patients with scleroderma. Again, you can see here that the RV ejection fraction was actually no different in this group, yet the patients with scleroderma had lower contractility and therefore reduced coupling compared to the patients with idiopathic pulmonary hypertension. Now, when a patient increases their heart rate, the normal response is actually to increase contractility as the calcium concentration builds in the cell. This is called the forced frequency response. And what you can see here, as we pace these individuals, the patients with scleroderma, which are the black squares, had less augmentation of contractility during atrial pacing compared to idiopathic pulmonary hypertension. So a little bit of a different definition of reserve, yet still showing contractile impairments. We then exercise these patients, and as you might expect, the patients with scleroderma exercise for less time. They achieve less maximal wattage. And although we were probably limited by numbers here, there was a trend towards lower peak VO2s and higher VE/VSO2 slopes. We ended up comparing these individuals at stage 2 of exercise, which was 25 watts, so relatively low level of exercise. In part, this was done because the scleroderma patients really had poor functional capacity. Now, when you look at traditional measures of function here, heart rate, stroke volume, and cardiac output, actually, you don't find any differences here at submaximal exercise between the patients with scleroderma and idiopathic pulmonary hypertension. Yet when you look at our more sophisticated measures of function, contractility, we can see there is differences where the idiopathic patients seem to increase contractility during submaximal exercise, whereas the patients with scleroderma really had no change in contractility, at least on average. Afterload increased similarly in both groups, and therefore the ratio of elastinces actually trended up in the patients with idiopathic pulmonary hypertension and trended down in the patients with scleroderma. But perhaps the most intriguing finding here was the changes in RV volumes during exercise. So the patients with scleroderma, again, the black squares, had significant increases in their end-systolic and end-diastolic volume during exercise. And so although there was no difference in stroke volume, ejection fraction actually fell in the individuals with scleroderma because the RV dilated. These are just some characteristic pressure volume loops from this analysis. And I'll just highlight the patient with scleroderma. With each stage of exercise, you can see there's progressive RV dilatation that occurs. And so what is happening here is that the patients with scleroderma are maintaining stroke volume and augmenting cardiac output by dilating. Essentially, they're using the Frank-Starling mechanism or heterometric adaptation to maintain their stroke volume, whereas patients with idiopathic, at least in a submaximal and in this cohort, as well as normal individuals, can increase RV contractility. Let me describe this for you here just with a schematic. In normal individuals, when we exercise, we have mild increases in afterload, but contractility increases to match that afterload. In idiopathic pulmonary hypertension, at least in our cohort and in submaximal exercise, There's a more robust increase in afterload, but contractility can increase to match. In the patients with scleroderma, their contractility is already saturated. That end-systolic pressure-volume relationship does not shift. And so as afterload increases, the only way to maintain stroke volume is actually to dilate. We wanted to understand if we could leverage this observation then to predict resting RVPA coupling. And so this was a relationship in 39 patients between exercise peak RV ejection fraction and resting RVPA coupling. And we see at least a modest relationship between this measure of RV reserve and resting RVPA coupling. And then we looked at different variables' ability to predict resting RVPA coupling. It was exercise RV ejection fraction that was the only variable that we found. And this was true if we looked at it and included resting RV ejection fraction, cardiac output, PVR, NT-proBNP, peak cardiac output, and VEV Sawtooth slope. Now, RV ejection fraction doesn't have to be measured invasively, of course. We can do this with MRI. This is an individual, a healthy volunteer individual. We have an MRI compatible bicycler ergometer you can see there. And of course, the normal response to exercise is to increase both RV and LV ejection fraction. But we know that that's not necessarily the case. This is one study, and there's a couple of these out here now, where they've leveraged this exercise MRI in patients with pulmonary hypertension. You'll see in controls on the left-hand side of the slide that all but one individual had a significant increase in their RV ejection fraction during exercise. But now on the right-hand side of the slide, look at patients with pulmonary arterial hypertension. And first note that all of these patients actually had normal RV ejection fraction at rest, but about half of them had a decline during exercise. Interestingly, the reduction in ejection fraction was associated with a higher VEV Sawtooth slope. But again, this suggests that these individuals might have hidden RV failure, and perhaps these are individuals that we may want to treat more aggressively. So in the last couple of minutes, I just want to touch on potential mechanisms for these contractile deficits that we discussed in scleroderma. One of our initial thoughts is that perhaps due to this microangiopathy, fibrosis, small vessel ischemia, that individuals with systemic sclerosis might hypertrophy less compared to idiopathic pulmonary hypertension, and perhaps that's why they don't have the same contractile generation. We had some initial data that suggested that might be the case, but this work by Ramjug and colleagues in a larger group found really no difference in ventricular mass index based on when controlled for PVR between these two groups. In our cohort of looking at MRI, for the most part, these patients were indistinguishable. There was a slightly thicker mid-ventricular free wall in the patients with idiopathic pulmonary hypertension, but you'll see no other differences in terms of geometry, basic measurements, or late gadolinium enhancement. I told you that we performed RV septal biopsies, and once we did this, my colleague Stephen Sue and my mentor David Cass took these biopsies. They were able to isolate single myocytes, and they skinned them so only the contractile apparatus was present. They then connected this contractile apparatus to a force transducer and exposed this myocyte to different calcium concentration to develop these force tension curves. Now, the black curve here represents tissue obtained from autopsy samples of patients without heart disease, so normal individuals, if you will. The blue line here represents patients with idiopathic pulmonary hypertension, and the red line are those with scleroderma. You'll see that the patients with idiopathic pulmonary hypertension actually had supracontractile force generation compared to normal individuals, where the patients with systemic sclerosis had impairments in that maximal force generation that can be obtained. Importantly, these myocytes all had similar cross-sectional area, so this was not an issue of just cherry picking the most hypertrophied myocytes. This had actually been seen before, at least the observation in idiopathic pulmonary hypertension. This is data from Sylvia Rain and the Buck Nordercraft group, looking at autopsy samples of patients with either idiopathic or Eisenmenger's related pulmonary arterial hypertension. And again, you can see those compared to controls, those patients actually had supracontractile force generation. Now, the decrement in force generation has also been seen. The first on the left-hand side is actually an ischemic mouse model, now looking at LV tissue. and more recently in patients with heart failure with reduced ejection fraction and RV dysfunction. So these are RV human myocytes, where you can see that there is a decrement in maximal force generation. And more recently, this has also been shown in HFpEF by Kavita Sharma and David Cass. Here you can see that the individuals with obesity and HFpEF, so perhaps a unique phenotype, actually had a decrease in the maximal force generation. And in fact, there was a relatively linear relationship between maximal force generation and body mass index. What we next wanted to understand is, could we relate this individual myocyte function, maximal force generation, to global contractile function? Again, because we did not perform free wall biopsies, we were only looking at septal biopsies. So could we relate that to global resting function as well as exercise physiology? And actually, we found a pretty strong relationship between resting contractility, which is in panel A, and the maximal individual myocyte force generation, as well as changes in contractility during exercise and the maximal force generation. Now, the last topic that I'll touch on is the idea of fibrosis. We know that individuals with scleroderma-related pulmonary hypertension have more fibrosis compared to idiopathic pulmonary hypertension, but it's a little bit unclear how much that contributes to the discrepant outcomes. And indeed, we found, looking at the biopsy samples, that there was more fibrosis in the patients with scleroderma-related pulmonary hypertension compared to idiopathics, as well as scleroderma without pulmonary hypertension. When we took those individual myocytes, though, and again, just looked at the skin myocyte, we did not find any differences in the passive tension that was generated, suggesting there's at least no difference in myofibril-mediated diastolic dysfunction. And we've actually never found any differences in diastolic function between the two groups. When we think about what contributes to diastolic abnormalities in pulmonary hypertension, it actually appears that the myofibril-mediated stiffness is the predominant mechanism, perhaps due to changes in titin, and that fibrosis, in fact, contributes only to a lesser degree. So to summarize what I've told you this morning, RV reserve is impaired in patients with systemic sclerosis-related pulmonary hypertension, and myocyte contractile function is reduced. RV reserve has prognostic and diagnostic value in heart failure with reduced and preserved ejection fraction, as well as in pulmonary arterial hypertension. RV reserve, specifically submaximal exercise RV ejection fraction, may predict resting RV-PA coupling, but how best to assess it, especially non-invasively, and how to use it clinically requires a further study. So with that, I'd like to thank you very much for your attention. Again, it was really a privilege to speak with this group this morning. I would encourage you all to consider a visit to Charleston next April. There's no snow on the ground in April, I promise you that, and it'll be our second annual Charleston HFpEF conference. So again, thanks very much for your attention, and I'll be very happy to answer any questions that you have.
Thank you, Ryan. That was a fascinating, beautiful clinical physiology kind of intervention. So there's a couple of comments there on the chat. So the first one is from Dr. Tharkar, who's a pulmonologist, and he wanted to thank you for a great talk. And he is happy to hear that the heart is at fault in sclerosis and pulmonary hypertension. But the questions are whether or not you have data on if current medical therapy for pulmonary hypertension has any impact on restoring PA-RV coupling in this population, or if the lack of said improvement further predicts prognosis in these patients. It strikes me that we need medications to try and address RV contractility rather than RV afterload in this group.
Yeah, so all great questions and important points. There's not a lot of data, at least with multi-beat pressure volume loop, showing that treatment actually improves coupling. This is actually something that Paul Hassoun and Steve Su, who are still at Hopkins, are looking at now. They're doing paired measures in patients with pulmonary arterial hypertension with these catheters and pressure volume analysis. So hopefully there'll be some data out there. One of the questions that we had wanted to understand is that would resting RV-PA coupling predict the response, right? So if you had someone who was kind of more severely uncoupled versus those who are more borderline uncoupled, would it predict response to therapy? And so we've been collaborating with Franz Richard at University of Arizona. And although he's using single beat metrics, and there's obviously some issues with that, we did not actually find really much of a predictive ability, although I suspect some of that relies on methodology. But great questions, hopefully more to come there. And I would love to see some therapies that actually target RV contractility. I actually don't know if you all have the ability to use levosimendan. We do not in the United States. It's not FDA approved, but I was fortunate to be part of the recent HELP study, which used levosimendan in patients with pulmonary hypertension-related HFpEF. And we actually saw some pretty intriguing results in terms of functional capacity improvements, as well as improvements in hemodynamics in individuals randomized to levosimendan. That was published in JACC Heart Failure. So, a lot of possibilities there, but we'd love to see, some medications that could target contractility.
So there's another question. Is there inotropes that can target RV combined with PA vasodilated to manage both idiopathic pulmonary hypertension and sclerosis, systemic sclerosis kind of?
Yeah, again, I think we don't know. I'd love to see some type of calcium sensitizer agent or some other inotrope that might help. If you think back to the 90s, Stuart Rich showed us that digoxin actually had some improvement in hemodynamics in patients with pulmonary arterial hypertension. It's probably not a medication we use a lot of. I spent a lot of my time dealing with patients with left heart failure, and there's some interesting work by Barry Borlaug in HFpEF in patients receiving dobutamine. And actually, what he showed is that a lot of those patients really didn't have much evidence of RV reserve with dobutamine, but dobutamine actually lowered afterload significantly. And I suspect that's what we see with levosimendan as well. So, I think when we use drugs like dobutamine, maybe we're actually seeing some afterload reduction as well, at least in the left heart failure population.
So Jason also congratulates you on a great talk. And actually, I think you answered this with that, whether this should be more RV-centric treatment for systemic sclerosis and maybe use levosimendan in that group.
I swear I did not see your comment when I mentioned levosimendan. But no, again, I think that's ripe for further study. We spent a lot of time actually trying to understand the mechanism between that that led to that impairment in contractile function. And some of our data I didn't show suggested that perhaps that troponin was being cleaved. And in fact, that was kind of similar to what was seen in left heart disease back in the 2000s. But we spent a lot of time trying to look for cleavage products, and we never really found much there. So again, I think, an area ripe for further investigation, but would love to see some type of therapy that could enhance contractility safely.
So you brought up an interesting concept of subclinical RV reserve failure. So, it's fascinating, but how do you target these people? Because if we identify these people early on, maybe you can prevent that RV. I look at it as an electrophysiologist, resynchronization, so decoupling. Can you actually resynchronize these people, couple again before they get to that point of no return?
Yeah, absolutely. So I think there's a couple of groups where I would like to see that looked at. So one is the groups with lower pulmonary pressure, what we used to call borderline pulmonary hypertension. Brad Marin has spent a lot of time showing that mean pulmonary pressure in the 19 to 24 range, as well as even lower pulmonary vascular resistance, all the way down to 2.2 Wood units, actually is associated with worse outcome. And it appears, at least in part, that's due to changes in right ventricular function, although it's hard to completely control for other variables. And so I would love to see studies in that population looking at RV reserve to see those that might benefit from earlier therapy. I think the other group, thinking about pulmonary arterial hypertension, is those patients who are on, dual therapy, who seem to be doing okay, but you're really on the fence about, do I need to add an additional agent? And perhaps evidence of RV reserve in that population would suggest, in fact, the RV is okay, On the other hand, if they don't have RV reserve, perhaps that's an at-risk ventricle that needs further treatment before they develop irreversible right heart dysfunction. So I think those are two groups. When we think about left heart failure, wearing my clinician's hat, it's how do we really understand some of these risks and need for needing advanced therapies, and we don't want to wait until the RV is completely blown to consider something like a ventricular assist device or even heart transplant. And so could that improve our risk stratification in left heart failure as well?
So do you think, for example, for systemic sclerosis and pulmonary hypertension, like a combination of an antifibrotic and something that goes directly to the reticular circle and increase calcium intracellularly would be kind of like the answer?
It absolutely could be. The antifibrotic is very interesting. People probably saw the phase 2 study at ACC using antifibrotic in HFpEF, which was intriguing. Certainly phase 3 needs to be done, but we certainly know there is more fibrosis in patients with scleroderma. So maybe that is part of the answer. So yeah, I think all of those would be it should be looked at.
And
Carlos, I'll just mention one of the things that I did not show, and speaking to the electrophysiologist, is as we've seen, what I showed you is with pacing, contractility increases. And one of the things that we published in the Blue Journal this last year is that in patients with pulmonary arterial hypertension, when their RVDP was elevated, as we paced them at higher rates, atrial pacing, cardiac output actually increased, which was very different than in left heart failure, where we know pacing doesn't seem to increase cardiac output. And so our theory there, based on a lot of Dr. Tyberg's work, is actually that leads to reduction in pericardial constraint and improvements in cardiac output. So very early kind of hypothesis generating studies, but something that we're pursuing nonetheless.
Great. And the last question is, do we need all the invasive assessment here, or are we going to move just to non-invasive assessment? Because the question here is that it makes it difficult to have these setups in every single center. So how do we compromise there?
Yeah, and of course the answer is it has to be non-invasive. As much as we all love to understand physiology and do these studies, it's not practical clinically. And so what we're kind of working on now is trying to further relate these gold standard measures to non-invasive measures of reserve. So we're performing both dobutamine and exercise echo, dobutamine and exercise MRI, and then performing these measures of reserve and measures of reserve in the cath lab with dobutamine and exercise to really come up with a surrogate RV stress test, if you will, because as much as I love pressure volume analysis, certainly it's not going to happen in our community centers, which are treating most of the patients.
Okay, well, thank you very much. That was a fantastic talk, and I appreciate you taking the time and spending it with us, and enjoy the weather down there, because the weather here is not that nice.
Yeah,
I hope to see you at some time.
Very good. Thanks so much again.
Okay, you take care.
Okay, bye-bye.
Bye now.